Hello, everyone, and welcome to today's edition of Patcast. Today is Tuesday, July 30th, 2024. I'm Rifat Mannan in California. Today, we are very delighted to welcome back Dr. Fausto Rodriguez, who is Professor and Chief of Neuropathology at University of California, Los Angeles, David Geffen School of Medicine. He has been a very prolific neuropathologist, as every one of you know, and he has delivered multiple lectures on our platform. And thanks to Dr. Rodriguez for your time for all of us. And today he is going to give a talk on intraoperative consultations in surgical neuropathology, and he is going to discuss it with some illustrative cases. So before we start today's lecture, we want to pay our tribute and homage to Dr. Christopher Fletcher, who passed away, and it's a great loss to the pathology community. And all over the world, he has inspired generations of pathologists who we all have learned directly or indirectly through him. And as many of you know, that he has described so many new entities in bone and soft tissue pathology. Some names include angiomyofibroblastoma, retiform hemangioendothelioma, spindle cell liposarcoma, cellular angiofibroma, to name a few. It's a huge loss for all of us, and we wish our deepest condolences to the bereaved family. With that, over to you, Dr. Rodriguez. Thank you for joining us today.
Yeah. Thank you for those words, for kind introduction, and of course to remembering Dr. Fletcher, who, like you mentioned accurately, has positively influenced our practice directly or indirectly. All right, we're going to talk today about frozen sections. So I'm going to show a few cases that that illustrate our current approach now in the molecular era. So we know that a lot of the entities now in the WHO are, many of them need molecular confirmation for final diagnosis, but frozen section still has a very important role in identifying and triaging tissues for appropriate diagnosis, clinical trials, etc. This is a slide that you probably are familiar with. I share it in many of my surgical neuropathology lectures and introduction, because I always want to remind every single time that anatomy and imaging findings are essential for any initial approach to surgical pathology specimens. And that is a very important in frozen section, where you have limitations of tissue quality and you are a little bit limited, you're on a time crunch to be able to convey some useful preliminary diagnosis. Most of these are preliminary right now, although you can get a very firm impression of where you're going. So just knowing the anatomy and the imaging findings, that can go a long ways to narrow your differential diagnosis and what you can do in the intraoperative setting. For example, one area in particular, like the pituitary, that you may say that diagnosis of pituitary adenoma is not that difficult, but if you don't know where it's coming from, you can have this very bizarre, large differential diagnosis. And once you know you're in the pituitary, your differential significantly narrows. It's just one example among many of the importance of anatomy and knowing this before or at the time that you're doing the frozen section. Let's go straight to some cases to discuss many of these issues. The first one is a 52-year-old woman that presented with a seizure. Seizure is a very frequent manifestation of a brain mass, particularly those that involve the cortex. So you will see it over and over in the clinical history for many of these brain tumors. This is the mass. You have here two images that are used very frequently in imaging. This is the T2 weighted image, where water and things and abnormalities many times are hyper intense. That's how I describe it. And you can see here, it's not subtle. You have this abnormality that is really very superficial, involving the cortex, and that many of these masses can present with seizures because of that involvement. And here is a T1 weighted image after contrast. And you see something the opposite of the T2 is dark, and you don't see any enhancement. You see the gadolinium is within the vessels, but the mass itself is not enhancing. So this is a non-enhancing superficial cortical mass. And most of the time, the differential diagnosis here, the main concern really is with a diffuse glioma of some kind. Okay, so we'll go to the slides. First one is going to be a smear. Can everybody see the screen, my microscopic screen?
Not yet.
Huh, okay. How about now?
Yeah, now we
Oh,
can.
you can see
Thank
the
you.
mic. Okay, so
Thank
this is the microscope. This is the smear. In frozen sections, in many practices, if you see brain frozen sections, you probably are going to be familiar with some of these smears. They're very useful because you use very little material, and many of these biopsies that you get from the brain, tumors or brain abnormalities are going to be small. So a smear gives you a lot of cytologic information that is obscured by the freezing process. So very important to become yourself familiar with what is normal cellularity, what is atypia that is not acceptable. Those are issues that are going to help. Precise grading is less and less critical because it's not possible. But you can do the extent that you can as long as you can recognize these as being representative of that lesion, and you can tell the surgeon with confidence, yes, you are giving me something that is pathologic and is certainly compatible with the imaging abnormality. That will go a long ways of helping the patient. We don't have to be heroes here or try to make precise diagnosis. It's not possible really with the different changes in classification. So if I look at this, I see a background that has a lot of processes, and that is what you see in the context of glial tumors. The cells are making processes. Now, you may say, well, is this really reactive or not? Or is it a tumor? And I think the main concern with that imaging abnormality is tumor. And you can argue, well, there's a cell here that has some processes. Can this just be a reactive astrocyte? And that is a very good consideration. The main thing that you're trying to separate here, reactive gliosis versus tumor. But if you see at the cells really are atypical. The main thing that you're looking for here is cytologic atypia. And you see these astrocytes here, many of them don't have these conspicuous processes. They're not evenly spaced. They aggregate in areas. It's not very cellular. So this is one that you have to probably spend some time convincing yourself that this is the atypia that you will associate with diffuse glioma. And here you see a more aggregation. There's variation in cellularity. This is something that doesn't happen very much with reactive gliosis, where the reactive astrocytes are evenly spaced. And have much more processes than the ones that you're going to, than the neoplastic astrocytes that you're going to encounter. So to me, this is very concerning. You don't even have to go to tumor here. I mean, it's acceptable to say glial atypia and convey to the surgeon you're concerned, but you would like to have more material, particularly for permanence. If they're not going to do any more, tell them to get more. Sometimes they will tell you, yeah, we'll give you some more additional material, but send it for permanence, and we'll sort it out tomorrow. And that is certainly something that is acceptable. This is the smear. The next one is the frozen section. And you can see here something that is problematic with frozen section. First, your cytologic details are blurred, are distorted. So cytology gives you really, it allows you to say what type of cells are you looking for. You can convince yourself on the smear that you have neoplastic astrocytes most likely. Here is a little bit tricky. You can argue there are maybe some reactive cells in the background, and you can have reactive astrocytes within a diffuse glioma. So those both can happen. And you see also something that is problematic with frozen section is these ice crystals. I think it's one of the main limitations for the evaluation of diffuse gliomas. When you this extent of what you need to see here, what to me is telling me the probably this is going to be a diffuse glioma, is that the cellularity is a little bit higher that I will expect for just normal brain and the cells that are bordering the crystals. And there are some frozen sections that are better than others. But here I tell you that to me here in this context, in this case, the smear was a better indicator of to me of diffuse glioma than this frozen section with all these artifacts. And let me see the next one. This is the frozen section control. And you see it's not the best. Even after the material that has been processed but has been frozen, this helps you a little bit more, right? I mean, we're closer to being able to call this diffuse glioma. You can see there is a lot of these are neurons here that have perineuronal satellitosis. Just to emphasize, perineuronal satellitosis is not a feature only of oligodendrogliomas. They have it a lot. It's a frequent feature in them. But any diffuse process involving the cortex can show perineuronal satellitosis. But here, you see, looks like we are already more firmly in the camp of a diffuse glioma. And this is the permanent, where unequivocally you have one. You have perineuronal satellitosis. Now the cells, you do have a few round cells, but there is pleomorphism here. You see there is variation in size and shape. And that is not the feature of your typical oligodendroglioma. So oligodendroglioma wasn't the differential diagnosis. They are frequently superficial. There are an important category of diffuse gliomas. You can argue that there are round cells like this that could be an oligo. If all the cells look like this, I will be entertaining that possibility. But then you have larger cells like that, hyperchromatic, lacking nucleoli. So this looks more like a diffuse glioma. We are a diffuse astrocytoma of some kind. The patient is adult, so we will be probably moving in the camp of diffuse astrocytomas of adult. And your two choices there, for the most part, in a hemispheric mass, for practical purposes, will be glioblastoma, IDH wild type, or an IDH mutant astro. And then we can sort that out with smears. You will not be able to do that on frozen, but just calling it diffuse glioma. And in this case, we didn't see much for proliferation. So even preliminarily, we can state that this is a diffuse glioma. Histologically, looks kind of on the low-grade camp, but molecular is necessary to sort out the final grade. We have some immunostains here. And again, I know it's a frozen section talk, but wanted to just follow up on the case. This is IDH mutant protein, and you can see it's positive. So it's an IDH mutant astrocytoma. And something that even helps you put it more in the astrocytoma camp is the ATRX. This is ATRX, and we can see that is lost in a significant population of cells. As long as you have a biphasic type of pattern, that is very helpful in suggesting loss. Doesn't have to be in every cell. You can argue some of these cells are a little bit irregular here, maybe part of the tumor, but for the most part, you can see that there is a real clear biphasic pattern of staining. This is for sure a neoplastic cell is completely negative, and many of them in the background are like that. So this is good for supports ATRX loss. And that combination firmly puts it into the astrocytoma IDH mutant camp. Now, we didn't see much for significant mitotic activity, anything else. So everything is looking like a grade 2. Are we seeing my screen now?
Are you sharing a slide or the
PowerPoint?
Yeah, we can see it.
We can see it, okay.
Yeah, thanks.
So back to this again, everything is looking low grade histologically. It's looking low grade by imaging. So we're almost there. We're almost at grade 2 astro. The thing is that the new WHO requires has introduced a molecular grading criteria as well. And that is happening more and more. Grading is not strictly anymore pathologic exercise or morphologic exercise. Now you need some molecular. Here is the fish for actually have here both 19. This is for 19. The 1P look the same. So 19, there was 1P and 19Q intact. This is an example of the 19. This is duplicated here. And you see here this is for P16 or CDKN2A, we see that there is loss of the whole chromosome 9 and some areas of heterozygous deletion where you have only 1 red and 2 green. So there's a little bit of heterogeneity here, some alterations there, but what you need really for elevating this to a higher grade is having homozygous CDKN2A deletion, meaning you'll have 0 red signals in many cells. So this one wouldn't be intact. Will this be will they have some effect prognostically? That's being studied, and maybe there is, and there are many other ways. There are some deletions that are smaller that are not picked up by fish. A lot of caveats, but when you see it, you can upgrade it to a grade 4. So if you have convincing CDKN2A deletion, you can upgrade it to a grade 4, and really is now necessary for optimal grading of these tumors. So the diagnosis here was astrocytoma IDH mutant CNS WHO grade 2, starting from the frozen section impression. Next case is a 60-year-old man that had some incoordination with arm and hand. And this is what you have. Another case of a hemispheric lesion. But here you have other some issues that are a bit more concerning, right? So this is the T1 post-contrast, and what you have here is really these ring-enhancing mass. That's always a problem. It's not a cyst. The wall is a bit irregular, okay? It's thicker than just a conventional cyst. And you do have some edema. Not everywhere, but you do have an associated edema, maybe actually part of the tumor. This is worrisome. It's a single mass with a lot of edema around it, and the main consideration, of course, here will be glioblastoma or some other high-grade glioma. Again, you don't even have to say glioblastoma. I don't say that on frozen sections unless the diagnosis is known already. I tend to call it high-grade glioma and probably convey that that's what's likely to be at the end. Okay. And you can see here, in contrast to the previous case, this is certainly has significant increase in cellularity. You have processes in the background as well, right? So it still tells you that probably you're dealing with a glial process. The cells are dark, clumping together in areas. Significant atypia. So this is nothing reactive will look like this. And this is a little bit easier compared to the previous one where you still are entertaining a possibility of a reactive process. Here, it's impossible for this to be, too much. You have nuclear dust. You do have mites here and there. Sometimes you don't see it. So even with high-grade gliomas, it might be difficult to find mites on the smear and in the frozen section. So that doesn't mean it's low grade. To me, this is a high-grade glioma, really, by smear. You have a few areas with dust, a little bit of some apoptotic bodies. So based on this, and based in the context of that imaging abnormality, I feel comfortable calling this high-grade glioma. But again, there's some mites here and there, and you can probably look for them. If you start seeing mites, that's concerning because again, they're underrepresented in the smears and the frozen section compared to the permanent sections. Here, a bit of the frozen section, you see the cellularity is really high. You don't see well the cytologic features, but you see you have necrosis. And that at first diagnosis in a diffuse glioma is always a bad sign. You may even have some fibrin thrombi, another feature that you see with high-grade gliomas. So here we feel comfortable placing it in the high-grade glioma category, and everything is fitting. Everything is fitting, from the clinical to the imaging to the histology. You may have some mites there as well. So, and again, do you have to call it glioblastoma? You don't need to. That information is not necessary. Sometimes they ask you, well, do you know if it's an oligo or a high-grade oligo? You say, it doesn't look like it, but that information is not really possible nowadays to do in a frozen section. You can convey your impression, but you don't have to write it down. I write down as high-grade glioma in this case, and that will suffice. Suffice for all practical purposes. And here is the permanent. You can see there's microvascular changes, fibrin plugs, necrosis of any kind. A necrosis of any kind is sufficient for a grade 4 in this context, in an astro, diffuse astro, essentially. Although palisading necrosis is more typical. Here is a very good example by contrast. There's probably both types of necrosis, but this is more your conventional palisading necrosis, which is typical of high-grade primary CNS tumors. So high-grade glioma will be the frozen section diagnosis. Make sure to convey that, for the surgeon to submit enough material for ancillary testing for immunos and molecular. That's needed nowadays. So it's not just having diagnosis on the piece. You want to have more material to really classify this tumor appropriately. Okay. So okay, let me show you some additional smears of high-grade glioma. This is another high-grade astro. Same thing. This one is not, the cells are not dispersed as well, but more obviously single cell necrosis, some background, a little bit of cleaning around vessels, but this ended up being also a diffuse high-grade glioma, astro. Okay. And so we have seen some tumors. We have IDH mutant astros that can be grade 2, 3, and 4. We have glioblastoma IDH wild type. And that case that I showed you, let me finish here. This is the fish. We probably don't need it in this case, in a sense that the tumor is firmly in the grade 4 camp by histologic criteria, age, but it was IDH wild type, and also had EGFR amplification, monosomy 10. You can see here by fish. A lot of cells with just 2 signals, a green and a red, losing 1 complete loss of the chromosome 10 and EGFR amplification. So let's say that we didn't have necrosis or even mitotic activity. Diffuse gliomas astrocytomas IDH wild type in the adults are, almost non-existent. There's nothing like a grade 2 anymore. Grade 2 astrocytoma IDH wild type. You can have other entities, rare molecular subtypes of tumors, glial, glioneuronal, that are expanding the WHO classification. But for the most part, your conventional diffuse astro that has these findings, IDH wild type, in that context, can be called glioblastoma. So that's why sometimes calling low-grade glioma in frozen may be misleading in a case where you're suspecting a glioblastoma, because you may have low cellularity, but still that it will end up, after everything is said and done, as a glioblastoma. So I end up calling those many times. If I don't have the high-grade features, I just call it diffuse glioma, diffuse astro, something along those lines, and say that histologically it looks low-grade, but certainly we will need to assess it at the molecular level to be able to make that final call. And glioblastoma, unfortunately, is one of the most common primary brain tumors. So it is, in that case, it's very likely you have an older adult, particularly with something that looks low grade, diffuse, hemispheric. Most likely it's going to be a glioblastoma IDH wild type, irrespectively of how bland it may look on the frozen section. So glioblastoma IDH wild type, CNS WHO grade 4. Now, this is a first diagnosis. Something that we're seeing a lot nowadays, in particular if you have a busy neuro-oncology practice, is treated tumors. So glioblastomas are, of course, very aggressive, and they are considered non-curable tumors that will end up killing the patient at some point. But it's manageable and it's treatable in the short term, and there are therapies that work. Radiation, temozolomide is being used in subset of patients with certain favorable molecular profiles do well for the meantime. So we are seeing that. Not only that, is that those patients are actually also looking for clinical trials, and many of them require tumor to document a recurrence. So the approach here is different than you have for tumor at first diagnosis. This case here is another smear, and I'm showing you a lot of smears of this diffuse glioma so you feel comfortable what a diffuse glioma looks like in smears. And there's a lot of processes. Larger cells, again, here it's difficult to interpret this as being anything else than tumor. Very cellular, okay? This patient had a glioblastoma that was treated. And what they're looking for is not a diagnosis of glioblastoma. They're not interested because they know that already. Probably you have done all the workup at one point in history, a year ago, 2 years ago, whatever the situation is. But what they're looking here is with these patients, they get serial scans and they start getting an imaging abnormality. And in that imaging abnormality, the differential is either tumor or treatment effect. And that's the difference that they're really looking for. Unfortunately, what you get is usually most of the time something in the middle, something that is tumor there that's probably sitting there. It's not proliferating very much. It's not very cellular, and admixed with all these treatment effect. And there is no real objective way of going around this. A lot of people approach it in different ways and say, use descriptive diagnosis. I many times describe it, state the amount of necrosis that we may be seeing, etc. And there are efforts right now of trying to make this more objective. But here, a case like this is too cellular. And if they ask me, what do you think of this? And I say, I'm more concerned that this is really active. I use the word active a lot, active high-grade glioma, meaning the tumor is not just sitting there being affected by the treatment, is really proliferating. And you can see here, this really looks fairly viable. It's again another nice example of a smear for a high-grade glioma. Something also I recommend when you're looking at smear, sometimes you have chunks, like what you see in the middle is a little bit less informative because you're gonna have thicker smears, the cellularity is not seen well. Try to go always to the edge. That's where your best cytologic features are identifiable. Some necrosis. Necrosis, I'm always very careful because you have a lot of artifacts um, in frozen section and smears, but this is probably necrosis here. I can tell you that is necrosis. So you have necrosis. Now, in this context, in treated tumor, you expect to have necrosis because that's what radiation does. It necroses the brain and the tumor alike. So here is not helpful for grading, except if you are convinced that it's palisading necrosis. Palisading necrosis is part of active tumor that's being actively doing something. There are a few macrophages in the background. That's okay. You can see a few macrophages sometimes with diffuse high-grade gliomas and areas of necrosis. So that's the smear. And this is actually the one of the frozen. So this is something also that you have to be careful of the mismatch between the frozen and the smear. If you look at this is very difficult to call tumor. This will be something I will call more, slight hypercellularity or glial atypia. This is not something that I will call tumor, what I'm seeing right here. It's not normal. There's an increase in cellularity, but I cannot call it tumor. Here you can argue there may be something there, but you don't have to stress your neck. Now, the smear here is really sufficient to be able to call it active high-grade glioma, to be honest. And here you can argue there's some here. But again, sometimes you may have the findings in the smear or the frozen. They are not always 100% together. So they are complementary to each other. And you can make the diagnosis as long as you know it's the right sample. Always important to know, review. But this will be something is impossible. I don't think you can call tumor 100% here, particularly after seeing that smear. But this is the permanence. And again, no question, this is active high-grade glioma. You can say recurrence or / persistence. Recurrence is not always the perfect term for these because these tumors never completely go away. The therapy, they take it out, but they don't take the whole thing away. You always have, these are not surgically treatable tumors, right? I mean, they go after they debulk them, but it's very difficult. You will never have a complete resection of these. So I tend to call it active high-grade glioma / persistent / recurrence or something along those lines. But no question, the idea here is that this tumor probably looks very similar to how the tumor looked before treatment. So it tells you that the current treatment is not doing very much and that you need to find something else to do. And that's how these patients start going into clinical trials and trying novel compounds that can have some effect. Okay, let's move to the next case. Next case is a 56-year-old man with a right temporal lobe mass. Very cellular smear again, and we have a theme, processes in the middle. These are glial processes. So it tells you that you probably are dealing with some sort of glioma, okay? So no question, nothing normal will look like this, right? Non-neoplastic brain will not look like this. And you can argue, well, these cells are ugly. A lot of variation in nuclear size, much more so than some of the tumors that we've seen so far. This one actually has a mitosis, so that is concerning. But there's a subtle clue here of where we may be going. The initial trigger will be this has to be some sort of high-grade astrocytoma of some kind. And it is, but we're seeing something here. And occasionally there are other clues that you can find in your smears. This is an eosinophilic granular body. So when you start seeing that, that's not a feature usually of your conventional diffuse gliomas that we have discussed. So it is a glioma after you have mites, concerning. But this happens to be the case, and that's a smear of this is the permanent of a pleomorphic xanthoastrocytoma. And you can here see significant pleomorphism. The differential diagnosis is with giant cell glioblastoma. I believe this one had a BRAF mutation, fit well clinically. And you see there are areas that are overlap with any other diffuse glioma that you can see. But this had all, we had several sections. I'm not showing all the features here, but you have areas here, pleomorphic, a little bit of this almost glassy cytoplasm that is typical. There were other areas with better eosinophilic granular bodies, right phenotype. So they are still, this will be, I believe, a grade 3. You do have mites, which is a high grade, technically speaking. The situation with these are that, they can still kill the patient, but they are part of the circumscribed glioma category. So they, in theory, with a very good resection and the right treatment, they may be cured. In practice, they do develop recurrences. They really can cause a lot of trouble, but it's certainly a much better diagnosis than having a glioblastoma. So pleomorphic xanthoastrocytoma. So not everything that looks that ugly is necessarily a glioblastoma in smears, and it's something to have in mind that you can have these tumors as well. Next case, 40-year-old man with back pain. And a mass, I don't have the scan, but it's the patient had a mass in the distal spinal cord. And this is what you have. Something I want to highlight here on the smear that is very helpful. You have the cells have a glial appearance, if you can tell. And they're kind of almost, you have to have a little bit of imagination, but they seem to be, a lot of what you have here is a vessel in the middle with a lot of these processes by these glial cells. Not very pleomorphic, right? There's little change in nuclear features, but you also have a bit of a suggestion of some myxoid material. So this is very critical. In the spinal cord, many times you're going to get very tiny biopsies for frozen section. You want to preserve as much as possible for permanence. So the smears are particularly important here to be able to preserve tissue. And it's very important to get familiar with lesions like this. So this type of lesion, to me, the main consideration is ependymoma. Sometimes you may get a frozen section. But here, you see, this is the frozen section. It's a little tricky. Here, the frozen section to me is not as the features are, you have tumor, but it's not as evident as the smear. I think the smear here is even more useful for the diagnosis. But this is the permanent. And you can see here a beautiful example of myxopapillary ependymoma that likes to arise in the distal spinal cord. Something that a very little piece for smear can help you guide you in the differential diagnosis. The smear, I think, to me was as close, there were not that many cells, but really was able to make that suggestion. It's important. These are surgical tumors in contrast to the diffuse gliomas. These are tumors that they want to resect to the extent possible. They will take as long as it takes to be able to resect it completely, because that is the main factor separating recurrences for patients and even death. If they get a complete total resection, that's the main prognostic factor in a tumor like this. And your frozen interpretation may help them guide. And if you tell them it looks like a diffuse glioma or something like that, they may not be as enticed to resect completely. But if you tell them it's an ependymoma, myxopapillary ependymoma, they will spend as much time as possible there trying to take it out. So that's one situation where your frozen section helps. Myxopapillary ependymomas, we know now the CNS considers this grade 2, so there's no that real push now to separating from other grade 2 ependymomas in the spinal cord. But once you start seeing myxoid change, distal spinal cord, most of the time, even focal, this will be the diagnosis. Next one is a 30-year-old man with a recurrent left lateral mass. Talk more about some of the chat in a minute, but 30-year-old man with a recurrent left lateral ventricular mass. And we are moving now into a situation, your typical diffuse gliomas, they smear very well. And then there are tumors that don't like to smear, and even in the ependymomas as well. But then we're moving into tumors that don't. This one is actually a little bit better than usual. Also a glial background. This one has a lot of glial background. But you don't see many cells in between the chunks of the smear. This one actually smeared better than the ones that I tend to be. I have to be honest with you on this case. Smearing a little bit better. And here the frozen section is very helpful because this is an architectural diagnosis for the most part. This is a subependymoma. Nodular, clusters. This one actually occurred for the most. These are very low-grade tumors usually, and usually even after partial resection, they grow very slowly. But sometimes they can recur, and that was the case here. Some of them, now you have this concept of mixed subependymoma, where you can have portions of conventional ependymoma that's still being sorted out as far as grading goes and prognosis. But this one looked good for it. And again, these don't tend to smear very well for the most part. This was one of the best I've seen in a sense of smears. So here, your frozen section is very helpful, again, outlining the architecture. A bit of pleomorphism here and there, that's okay for it. Not much for mitotic activity. Case number 6, 70-year-old woman with diplopia, vertigo, tinnitus, and sensory changes. Actually, and you have a mass here. And this is the problem. You have a mass here is in the cerebellopontine angle. The most common mass there will be a schwannoma. That's a tumor that we see in very commonly on BC neurosurgery services. This one is cystic, certainly part of the differential diagnosis, but I will have to bring your attention. It's more of a cyst with an enhancing mural nodule, and that has its own set of differential diagnosis. In the supratentorial compartment, you have to think about pilocytics, PXAs, gangliomas, so it has its own. You see the border is kind of smooth. It's more of a cyst almost compared to the glioblastoma that I showed you earlier. And this is a smear. A better example of a case of a smear that is not very good, and that in effect, that gives you some clues of what this may be. Kind of, you can say, well, it looks a bit glial maybe, but you see it doesn't smear very well, very bloody. So it's something that actually helpful in it helps suggest this case, the diagnosis here. Very bloody, difficult to tell. You say, well, what can the big many tumors can have blood and all that. So you have a relatively wide differential diagnosis. This is in the cerebellopontine angle. And the frozen section can be difficult. The smears in this case are usually difficult. As frozen sections are difficult because the quality is not the best. And obscure, you have some cerebellum here. And this is your tumor. And you see these pale cells with this very delicate capillary network. And this is an hemangioblastoma. The cells here, the quality of the stromal cells is not that accentuated, but you see it. There are some subtypes. One is called sometimes cellular that have these nests and less stromal vacuolization in the cells. But this is a hemangioblastoma, and it's tricky if you don't suspect it prior to frozen section, because these cytologic features are not seen very well in the smear because it just doesn't smear well, and in the frozen section. So there, the imaging helps. The presence of in this one actually was suspected by imaging. You have a cyst with a mural nodule in the posterior fossa of an adult. The two more common tumors that you're going to find are hemangioblastoma and pilocytic astrocytoma. So that's how your differential gets narrowed with some of these imaging findings. Have a couple quick ones to wrap up. So it's a WHO grade 1 tumor. 60-year-old woman had a syncopal episode. And we have here a large mass. What is important to have in mind here is this tumor is actually inside the lateral ventricle, okay? There are a few features here. You can say, well, you start thinking about the differential diagnosis of intraventricular masses. Here, in addition to that, there's something that is very helpful, and it's the imaging findings. And many times, even though this is an uncommon location for this lesion, this is suspected by radiology because of the imaging features. You have something that this is T2, Most of the tumors that you'll see are bright. You have here a little bit of edema around the mass, but this tumor is kind of dark, and that is something that you see in tumors that have high fibrous content, and it's very typical of this one. You also have quite a few vessel, or what they call phloboids, around it, so it's kind of vascular but dark, and it has uniform contrast enhancement. Those are features that actually make you think of this, even though it's not the most typical location. And you will see it in the radiology report for the most part. This is the smear. And if you see it at first glance, you can argue, oh, well, this has to be something glial, right? You have a lot of processes. Glioma is in the differential diagnosis for sure. But actually, if you can see the cell, even though they're, the nuclei have something very typical. They're kind of oval, not much for change, kind of very fine chromatin. It's a tricky one. I'll tell you, this mirror is tricky, but I wanted to just share because I have a good example. Now you start seeing other things. Very nice intranuclear inclusions. So yeah, differential diagnosis there. We have an intraventricular mass, and we'll go through it in a moment, but this is the H&E here. A little bit spindle in areas. Samoma bodies. And you start seeing here something that resembles morphologically a little bit better a meningioma. So this is an atypical meningioma. I had enough mitosis to put it in that category. But you see, it doesn't have as much pattern. It doesn't have all the meningothelial whorls. You start seeing some here. A lot of collagen. Here, a little bit of more whorling, but it's not a dominant feature. And the important thing to have this in mind that sometimes this happens in the smears. When the smears, in a conventional case with a lot of whorls, it's very easy. But it's important to get used to what the meningiomas look on the smears because it can be a little tricky to interpret in the individual cases, as was this one. The background had a lot of processes. You may be tempted to call it a glioma. But this ended up being well evaluated, and diagnosis was meningioma, typical. And again, they can occur inside the ventricles, but the features, the imaging characteristics are very similar to the ones that occur in the dura, and the radiologists are very attuned to identifying them. Final case, this is a quick one, 50-year-old woman, had a new onset of confusion and aphasia with a fall, had this mass, which was interesting in which it was bilateral. It had an attachment to the falx cerebri, had also ring enhancement. This is something to have in mind. And there is another extra feature here. This is a T2. You have all these increased T2 hyperintensity that goes well beyond the vicinity of the tumor. So this is something that is a subtle clue also what this could be. And this is disproportionate edema. Okay, so this is not something that you will see usually with a meningioma, which is in the differential diagnosis, given the attachment to the falx, or even a smaller diffuse glioma. This is something that this type of massive edema is something that you see with these lesions. And I only have a smear here for you. The patient has a history. And of course, I think this is something that probably most of the audience can recognize well and see more than I do. This is a metastatic carcinoma of the breast. We do see it. It's part sometimes. Many metastases, patients that have metastases, maybe they're not going directly to surgery. It has to be taken into account. Metastasis is the most common brain tumor overall. So it's something that is important to have in mind. They are the most common tumors that are going to be affecting the CNS. Not all of them go to surgery because sometimes are multiple. Some of them, the patient may already be in palliation. But you do it if they are able to, the surgery here can have some purposes. First of all, clinical trial enrollment, palliation, or sometimes you have something like these in which you have kind of like almost a single mass attached to the dura where you may have a differential diagnosis. And sometimes there are mets that can present as a single mass that grows slowly over time. And that then raises a possibility of a primary brain tumor. And you are able here with a smear to really separate it from the more, in this case, will be high-grade glioma or meningioma, the main differential diagnosis. So some also all these mets are treated with radiation, with focal radiation to alleviate symptoms, and then many of them don't require surgery. Okay, have a few multiple choice questions to wrap up. What is the main cytologic feature of diffuse astrocytomas and smears?
I don't see much answer. Let us give them a couple of minutes. There might be a little lag. I think it is good. People are going for A and also E.
All right.
More
actually,
for A.
E. So E is actually, they're not even. So what is evenly spaced astrocytes with numerous processes is actually what you see with diffuse with gliosis, subacute gliosis. That's what helps separate it. They're not as evenly spaced. The astrocytomas, you get more clumping. And really what you're looking for is nuclear atypia, atypia of cells that you know that they're not really, don't belong there. Reactive astrocytes have kind of bland nuclear features actually in a lot of processes. So, okay, question number 2. Which of the following tumors may be encountered in the lateral ventricle?
I think I see some answers for D as in David.
All right. And that's actually the case. So it's D. So the others are technically not seen in the lateral ventricle. So ependymoma can also typically seen also in the fourth ventricle in adults, but occasionally you see it in the lateral ventricle. So that's the right choice. In our case that I shared with you today was subependymoma of the lateral ventricle. Something that is distinctive about these in the histologic level is that they tend to have a lot of microcysts. So question number 3, what is the effect of frozen sections on diffuse glioma samples?
I see answers going for B, B as in boy.
All right. So that's correct. The other things, yeah, it's not as, you can have some problems with immunohistochemistry, but you still can apply it in molecular as well. The main thing is the ice crystal formation. It's one, I think, of the problems for interpretation just by frozen section. That's why I like to use smears a lot on these diffuse gliomas, not only because it preserves tissue, but you have this ice crystal formation that makes it very tricky to evaluate. And they're pretty susceptible to that. Okay, the final question, diagnosis of myxopapillary ependymoma on frozen section is based on
I think I see C as in camel.
okay. I believe it's a question I've asked before. And yes, these pseudo-rosettes with this basophilic cuff is very typical, particularly of a lesion that they tend to occur in a frequently distal spinal cord. That's where you're going to be encountering them in the CNS examples. They can occur in other areas sometimes, but that is the main location. And when you see these pseudo-rosettes with basophilia, again, it's a very important tumor to detect in frozen sections because it's going to affect really the extent of resection in these patients in some cases. And I think that's all I have for now from my end. Happy to, if we have time, I'm happy to answer any questions that have been arise that we haven't covered.
Thank you so much, Dr. Rodriguez. There are a few questions, some of which I have put on the chat box. The first one, I can read it for you. One is that someone wants to know the cryostat sectioning temperature, and the comment is that these sections are so good, so they want to know about it.
Oh, yeah, there's no changes. The same, I wouldn't do something separate for these versus other frozen sections that you may do. It's the same cryostat. I don't think there's any difference as far as I know. I can double check that for our next, maybe do something more about technical details of some of the frozen section. But yeah, some of these, not all of them look like this. There's variable. Some cases are better than others. But frozen section artifact is something that you're going to encounter a lot. That's why it's very helpful to get used to the differential diagnosis by location. Take your time reading the imaging report, what the surgical impression is, discussing it with your surgeon if you are, if it's really critical, and getting very familiarized with smears. I think those features, even tumors, like you said, meningioma, you can diagnose it by a frozen section. They freeze well, but certainly the smears are actually very helpful in individual cases, particularly like a case I show you where there's not that many whorls, the tumor is cellular, you have still a differential diagnosis. I think there, even though that smear to me shows cytologic features of meningioma, so it was very helpful.
Right. For frozen section, again, there is another question. I see that. Do you have any specific advice while cutting frozen sections, preparing frozen sections, etc., for good quality for brain tumors?
It's just practice. The more you do it, the better you become at it. It's the same as anything else. The smear is something that will be because if you give me the choice, let's say I don't know anything about the tumor, I have a choice of a smear or a frozen section. I will choose the smear even without knowing much about the tumor. The tumors that are more solid, the subependymomas, the frozen section gives you more information because it's an architectural diagnosis. Many meningiomas you can see them better in the frozen section. But if you have a choice of become very proficient at them, and the main thing there is to have the right, your hematoxylin, eosin set up well, and basically after you smear it, you put it right away, fix it right away. So that's the main thing. That delay, air drying is the thing that's going to cause you a lot of more problems. So if you're avoid air drying, do nice staining, and get used with the smears, I think that's the best thing. The frozen is just practice. And it's not really different than other tissues. I find, for example, just, the brain is a fatty organ, right? But, cutting fat, if you're very used to cutting fat, for example, for breast specimens, you should be able to do good frozen sections for brain.
Right. You already mentioned that, Dr. Rodriguez, someone asked this question that how to make smears for the beginners, like, I mean, from brain specimens for which has come for frozen
Yeah.
sections. Any
The main thing is
advice?
when you have small specimens. Let's say, and the best example is a stereotactic biopsy, right? That you have a needle. So you have a needle like this. And let me see if I can put it. Yeah, right here. You want to take both ends, a little tiny piece. I tell you, it's just a millimeter. It's very small. You put it in the slide, and then you squeeze it gently, smear it quickly, and dip it quickly into your fixative. That's the main thing. You just get used to doing it, and with time, it's gonna become better. If you squeeze it too much, you're gonna break a bunch of cells. If you don't squeeze it enough, you may get it. You get a feel for it, then you don't get a good smearing process. But squeezing it at kind of moderate amount of pressure quickly and dipping them very quickly into the fixative. After that, you can take your time staining it and all that. But those are the tricky ones. The you don't want air drying artifact, and you don't want to squeeze them too much. Those are the two things, and it just takes a little bit of practice. But that is really what the smear is. You just need representation of the tissue. I'd say that the stereotactic, because that way sometimes you may have the tumor at one edge but not the other. So I take for the stereotactics, take one piece in one end, and then most of it is represented. And then you're going to have to do, if you have a larger mass or something like that, you want to be looking at different areas that are a little bit heterogeneous. There's heterogeneity to see which one may be the best, but you may need to do more than one if you have different areas that you want to represent.
Right. So you said that after the smear, we should put it immediately into fixative, isn't it? That is very critical,
That's
right? So that there is no drying.
right.
And then after that, the H&E is very similar steps like any other frozen section, right?
That's right. That's
Okay,
right. Use
cool.
the same what you're gonna be using for your typical frozen section, the same process.
So in the same line, there is another question from another viewer is, can we do task preparation for these tumors?
You can. I think that they don't work as well, to be honest. I don't myself do them. Um, if you're you're used to examining them, and I feel that you have, a lot of air drying artifacts, and for tumors that don't smear very well, probably their touch prep is not going to help very much either. So I mean, if you use it, everybody does things slightly different. I'm going to say it's not helpful, but for me, I haven't found them in this context very helpful myself.
Right, maybe like the tissue will be not well represented on task prep because it is still like hard tissue. It is not like the bone marrow smears or something, right?
Exactly.
Or
And
a lymph node.
with a piece, that you're getting a little bit deeper into this. With a touch prep, you will be only assessing the surface. And again, these are small, relatively small biopsies. It's not like you have a big tumor that's right there. You know that the whole thing is a tumor.
No, thank you. There is another question about reporting meningioma on frozen section. So how far one should go in diagnosing on frozen section and how to grade or should be grade at all? There is a question on that.
Yeah, that's always an excellent question. Again, it varies a lot. What some surgeons are. Many times, it's important to separate what is really important from for intraoperative decision making versus what the surgeon is curious about. Sometimes if it's just, sometimes they may ask you, what is the grade? Is it really an oligo? Is it really an oligo? Sometimes you cannot call it an oligo, and you need ancillary tools to make the diagnosis. So sometimes it's because they want to talk to the family after, which is, again, I understand the feeling is, the family is anxious. They want to get some hope, the patients that, there is something, more favorable in their diagnosis, that you can tell that it's low grade, that is all that. But really, a lot of the grading, as you see, even the diagnosis of glioblastoma is not as straightforward as it used to be. You have to exclude IDH mutant tumors. You have to exclude histone H3 mutant tumors. You have to exclude a lot of things. And, sometimes now it's molecular rather. You can say, oh, it looks low grade. We used to call, grade 2 astro or something like that all the time. But that doesn't exist really anymore, So a lot of that is you need ancillary testing for it. And then you have the rare, bizarre things that we see not uncommonly. You have all these expanding category of molecular defined entities that the frozen section is not gonna tell you anything about. So that is one thing. Regarding meningiomas in particular, the grading, if you don't see mites, you still, remember with meningiomas in particular, you have a lot of underrepresentation, because what you're going to see is you may see a small biopsy. Sometimes they give you a little piece, and then they're going to take, if the tumor is big, they're going to take it out, and you're going to have a tray of slides that you haven't seen and frozen, right? So the possibility that you have an atypical tumor there, the borderline atypicals, you may not detect it. And in fact, most of the time you don't detect it on the frozen section time. You will see it after looking at mites, doing Ki-67, looking very carefully through all the tissue. Now, if you see a lot of mitosis, you can always say, yes, this is, you can convey, this is mitotically active, this is worrisome. This is probably at least a grade 2. Because once you start seeing mitosis in frozen sections, you will see more on permanence. That is the ballpark, really. But if you don't see any, it doesn't guarantee that you're not gonna see. You're gonna see much more material. So meningioma is really my diagnosis most of the time, and the grade 2s and 3s are less common than the grade 1s. So grade 1 and maybe the frozen, but we'll be doing the evaluation on permanence to grade it appropriately.
So there are two questions which are not exactly related to frozen section, but somewhat related to tumors in general. One question is molecular analysis necessary for IDH mutant astrocytoma? That's number one. And the second one is quite related, that are you still able to diagnose most cases on H&E and immuno, or are you doing molecular on majority of the cases?
That's a great question. So one of the things, the IDH mutant astros, for the most part, to be able to call it an IDH mutant astro, you may not need, in most instances, molecular characterization. You need your immuno that detects the IDH1. So if it's positive, then it's fine. Then the ATRX immunostain, if you have loss and the tumor really looks like an astro, then you can put it in the IDH astro. One P19Q co-deletion is done frequently. You need it for the diagnosis of oligo, but it doesn't mean that you have to do it in every single case of astro if you don't have that tool available to you. I think if a tumor that looks like an astro is IDH mutant and has loss of ATRX, to me that is an IDH mutant astrocytoma. Now the problem is grading, because if you have morphologic features of 4, let's say mitosis, microvascular proliferation, etc., you're fine. Probably you don't need anything else. But if you have a grade 2 or a grade 3, you need to do the P16 testing, which, sometimes we do it here by FISH, but it doesn't cover all the alterations. Some people do it by NGS, but you really need that to be able to call it a grade 2 or a grade 3, because if you have these deletions, it will make it a 4. And it's unfortunately the WHO, that's the WHO guidelines now. So you need at least, I will tell you, at least the P16 assessment nowadays to be concordant with the WHO. Now, do I do it in every case? I have to tell you, I always mention I have 2 different practices, really. I have my in-house practice where we do with our patients, and we in communication with the oncologist, we try to do as much as possible in a sense of precise characterization. Though some cases I get them in consult as a second opinion. So in those, it may be before molecular is being entertained, and I don't automatically do molecular, because the lab that may be sending it, they may already send it to molecular somewhere else, or they may want to do something somewhere else. I don't know the billing situation with the patient. So there, I approach it in a more global manner. I do try to give a global diagnosis based on what we have, and advise molecular for more precise characterization. For some instances, a 75-year-old that comes with a high-grade glioma may be all that you need to do. They may not need very much, beyond that. The tools, the drugs may be the same. They may be treating the same way as a glioblastoma, high-grade astro, or any other thing. So they may be, depending on the location or the plan, the treatment plan, they may not need a fancy molecular testing for it. So I give that the benefit of a doubt, that yes, we can do all the molecular that we want. We do a lot of NGS in-house and some of the sending as well, but I leave it to the discretion to the submitting pathologists and clinicians, and sometimes we converse and then we move forward. But sometimes they say, well, let me talk to the patient, or we'll send it somewhere. We have a contract with this other lab, and sometimes we get the information later, and then we can upgrade it. Sometimes we do this addendum, or we do an integrated diagnosis, and we incorporate all this information and upgrade and update our diagnosis based on that.
Right. Thank you. There is another question, and both there are two questions actually related. So on frozen section, how do you differentiate between reactive gliosis and low-grade glioma? That is number one. And second is like, how do you differentiate between low-grade and high-grade glioma on frozen section? Any particular quick clues about it?
Absolutely. We touched a little bit, but I wish I had also a diffuse gliosis. I'll have it, and we can discuss that in another session. But the diffuse gliosis, usually you have the evenly spacing of the astrocytes. That's very typical of diffuse gliosis. They are evenly spaced. They respect their boundaries, and they have not so much nuclear atypia, but a lot of cell processes. That's the main thing that you see with diffuse. What happens is with diffuse gliomas, you can have some reactive astrocytes in between, and you can have edge. The edge. You might have also some areas that don't have the tumor. There are caveats there, but evenly spacing with a lot of processes favors diffuse gliosis. Atypia, the nuclear atypia, the nuclear features. The cells are hyperchromatic. They have proportionally less processes, and they tend to clump together to make clumps. Those are things at the very low grade of the spectrum. It's very difficult to separate those two, and you may not be able to. Sometimes I just call it mild glial atypia and tell them, I'm concerned, but please give us more, to the surgeon, or even for permanence for sure. We are here indecisive at this moment. This happens at frozen section, and they are okay with that. So that is the main thing. So that's low grade, which is very tricky. Then low grade to high grade is a little bit easier. If you start seeing mites in a smear, it's likely to be high grade, right? Because you don't see that many mites. If it's very cellular, even if you don't see mites, it's likely to be high grade. So it's a degree of cellularity and mitotic activity that I used to call it high grade on frozen sections and smears.
And related to that, do you call glioblastoma on frozen section, or you just advise to leave it as high-grade glioma?
High-grade glioma. Because now, again, most likely many times when you're entertaining the diagnosis, that's what's going to be. But there's a lot of molecular categories now. There are tumors that you see it on permanence. You say, it looks like a glioblastoma probably, but it's funny. And then you send it for other ancillary testing, and you will have a distinct molecular category. So to me, it's more accurate to call it high-grade glioma. They don't need to know it's a glioblastoma. It's not going to change the approach of the surgery or anything like that. And you will still be it will be an accurate reflection of what you have. So high-grade glioma is really appropriate. If you think about it, regardless of what happens later, the molecular stuff, if you feel convinced it's a glioma and it's high grade, you can identify those features many times by frozen section evaluation. And that's going to be true. That diagnosis is going to be true forever, right? So it's going to be true forever, regardless of what all the fancy molecular workup happens later. They may put into a glioblastoma. They may call it a histone H3 mutant glioma, whatever, or, high grade associated pallor features. There's a lot of different categories now that look very similar to a glioblastoma that you are only able to tease out with molecular, but a high-grade glioma category will be true, and it will suffice for any sort of intraoperative management.
Right. One last question, Dr. Rodriguez, that diagnosing metastatic carcinoma from primary brain tumors on frozen section, is it difficult, or do you have any specific advice for that?
No, for the most part, they're easy. The smears are very helpful because, your carcinomas look like, they look like carcinomas. Melanoma is relatively easy to recognize. Many times you have the history. It's rare to have just I say occasionally you have a single met. Most of the time you have something that's more multiple. You have the history there. You see all these features that we were talking about, glial processes. That's something that you don't see in metastases, right? So that is relatively straightforward to separate. Metastases, they have, depending on the type, they tend to have clumps, and they really look like carcinoma. And we see that more, in a general practice than primary brain tumors. So there are overlaps. There are gliomas that have epithelial differentiation, for example, but that's an extreme example of something that can happen. But in the day-to-day basis, they are relatively straightforward to separate, and smears can do that for you.
So there is one last question, a little unrelated from another viewer that for today's quiz that you have asked, is 50% pass is allowed or not?
Of course. It's more to highlight, again, these are not even the best, these are not questions that I have, evaluated properly with guidelines to see if they are some of them are not good questions, actually. It's just something that I try to make, to put it in a sense, to review the material that we had before. In fact, I think any passing number for me is appropriate here.
No, with that, we have come to the end of today's session. And thank you again, Dr. Rodriguez, for this excellent lecture. We really appreciate it, and for sharing all your knowledge and discussing so many difficult questions, how we deal with frozen sections. And you would be happy to hear that you had a lot of viewers who joined from different parts of the world, and people joined from countries as far as Italy, Kenya, Mexico, Brazil, Ghana, Argentina, Saudi Arabia, Pakistan, Philippines, to name a few, and many joined from US as well. And there are a lot of residents who joined from Jorhat Medical College in India. And thanks to the students, it's always good to have residents taking interest in learning. Thanks to you guys. And our next lecture is coming up. So that is on August 6th, and we will continue with our series of lectures on digital pathology or artificial intelligence. And Dr. Emma Fart will deliver a lecture, and her talk is going to be on image analysis, and it's named as, it's not magic, it's math, image analysis and Photoshop. So hope to see you on August 6th. And we are also planning a tribute to Dr. Fletcher. So we will come up with the date soon, and hopefully, probably it's going to be on August 9th. So we will announce about that later. And thank you again, Dr. Rodriguez. It's always a pleasure to have you.
Hope to see you in the future again with other practical topics.
Bye.